Okay, everybody, I know we have a couple people still getting plates, but we're going to go ahead and start the program so we stay on track. I did want to call up first Debbie with Theater of Memphis, just to say a couple of words about this beautiful space.
Well, welcome everyone. I'm going to do without a microphone because if we cannot speak loudly at a theater, then something's wrong. But I want to welcome each and every one of you to Theater of Memphis. I am so thrilled that First Horizon reached out to me to ask if we could have a luncheon here. This is the first luncheon that we've had, so we're so excited that it's your group. But again, Theater of Memphis celebrating 101 years. We just underwent a major expansion and construction, and it all coincided with the pandemic, and that was not planned, but fortunately construction went on. But we hope that you enjoy today. We are grateful, and I know you are, to First Horizon because they have been our season sponsor for 10 consecutive years. But also, we look forward to seeing you at some of our shows. We open a fantastic hysterical comedy next week, The Play That Goes Wrong. The set is as much of the star as the actors are. And then we will end our season with Mary Poppins, as well as a Sherlock Holmes mystery. And then we've announced our season, and to kick it off, Sister Act, the musical. So we produce 12 musicals or plays per year, as well as our outstanding outreach and education program. Again, enjoy today, and thank you for being here, and welcome. Thank you.
So, speaking of First Horizon, Margaret's been in First Horizon, have been a longtime friends of MGMA, but Margaret has, I think, a door prize.
Yeah.
So we have this fishbowl.
First, I'd like to just say that, echo Debbie's comments and thank everybody for being here. I do have a few members of my team I'd like to recognize. Debbie mentioned Elena Hu. She is new to our medical private banking team. I'm super excited to have her. Chris Webb, who's also a medical private banker with us, and Angela Gustafson, who's on our treasury team. So we have a $100 Visa gift card that I neglected to bring from the office, so I'll send that to you. It's been that kind of week. A week of a holiday is always fun at the bank. Yep. It needs to be a member. Janice Harville Lowry.
Janet's been winning MGMA prizes since. Okay, we also have Jesse Lawler from SPMIC. SPMIC has also been a longtime friend of MGMA. There's Jesse.
I guess I don't need.
I know, I'm the only one using it.
Well, I get the easy job. I just need to give stuff away, which is always fun. But I'm a sorry stand-in for Amy Herbers, who is our Memphis account executive, and she sends her regrets. She's on vacation this week and was begging me to come and make the job down. I work out of our Brentwood office. I've met many of you over the years. Been with SUMIC. This is my 15th year. So if I haven't met you, I'm not doing my job, and I apologize. But one thing, everything is going well with SPMIC, very stable. One thing I do want to point you towards, if you're a policyholder, if you have what's called a Vantage account, which is our online platform, we just continue to add to those online resources. And so please go to our website, take a look, and see if we can help you with anything with your practice.
Robert Burns. So Robert, I think it's a AHP wireless
It's a
speaker.
Bluetooth sound bar. Yeah. Hope you enjoyed that.
Thank you. Okay, so we have just a couple of reminders and announcements. Our next MGMA social is April 6th at 5:30 p.m. I don't think we've settled on a location just yet. And then our next luncheon event will be May 4th at 11:30. I hope that you all will join me at the MGMA Spring Conference. It's in Gatlinburg. That's April 26th. And just a reminder, in October, the MGMA National Conference is actually in Nashville this year. So a plug for that. I know we've had a couple of us, including me. It's a great year to do your fellowship. There are some new pathways that make it a lot easier to become a fellow. I did mine this year, so technically I guess I can walk at Nashville. But it's pretty, not easy, but there's new pathways available. So get on the website, take a look, get some extra letters behind your name. It's good to do. Just a reminder too, we still have although our board, all of our seats for the committees are full, we're always taking, if you want to get involved on the subcommittees, please reach out to Cara, me, Clint, one of us can hook you up with some of the board members here today. Alright, so I think we are ready to get started with our panel. So I'm going to be introducing, Chantel is going to be our moderator today. Chantel Leatherwood has been with Christ Community for 2 decades. She started as an administrative assistant and then practice manager for 10 years, chief administrative officer for 4 years, and now CEO since 2017. During her tenure, Christ Community grew from 350 employees and an annual budget of $30 million to 560 employees and a budget of $53 million. Chantel is a native of South Memphis and a Central High School alum. She has a BS in Healthcare Administration and a Master's of Health Administration from the University of Missouri. So everybody welcome Chantel.
Thank you. It's a pleasure to be here with you today, and I want to thank Clint for asking me to facilitate today's event. But without further ado, we're going to actually move to introducing our panelists, who I'm sure you're very excited to hear from today. So starting with Brian.
I am Brian Barbato. I'm the CEO of Mid-South Imaging and Therapeutics. We are a radiology practice here in the Memphis region. We work predominantly with the Baptist Health System, but also work at LeBonner and a number of physician practices around the community. A lot of you all I've known for years, and so I'm very happy to be here and participate, and thank you, Clint, for inviting me. I realized that there were about 10 people that said no, and then you called me, so but better late than never. No, glad to be here. Hope to give you some information.
My name is Kim Avery. I'm the CEO of Mid-South Pulmonary and Sleep Specialist. I have been there for a long, long time, about 24 years. I got there out of law school. They hired me in my last year of law school, and when I started, we had 5 physicians. We now have 22 physicians and 21 acute care nurse practitioners. So we are a pulmonary, critical care, intensivist, and sleep practice. In 2022, we opened a large sleep center, and we service the whole Mid-South region. We're one of the largest single specialty practices that's private of this nature in the Southeast. And so if you have breathing problems, you can come see us. And if you can't sleep, we can try to help you.
I am Shannon Tacker. I'm the CEO for University Clinical Health. We are an academic practice plan affiliated with UT. We are not part of UT. We are 501c3 standalone. We have about 185 providers, about 500 employees. And I was a little surprised when I was asked to sit up here as well, but I'm excited to be here.
Thank you all. So let's start today's discussion. We have just completed a year where many of us have finally been able to bring our heads out of the pandemic sand, and some of us more than others. And so what would you all say that is your number one accomplishment in the last year, having taken your heads out of this COVID-19 battle?
Yeah, I mean, it was, I don't know if this is a good sign or a bad sign, but I started my career back in my home state of Louisiana, and when I moved back home, Katrina hit, so that was, a learning experience. And then, I never thought I'd go through a pandemic, but we did, and so I'm hoping to have a little bit of calmness for maybe a bit. But number one is the people that we work with, and we have approximately 125 employees. That includes physicians, about 50. We have about 50 provider physicians, and my proudest thing is that we didn't lay anyone off. We didn't cut anyone's benefits. We didn't cut anyone's pay. Now, certainly, you know, government funding helped with that, with PPP loans and HHS grants, certainly helped bridge the gap. But, you know, as most of us in healthcare, we work with a wide range of employees, and that job means a lot to people, and being able to retain everyone and keep their benefits and their compensation whole and not take any cut was really, really positive for me personally. You know, and that's probably number one, I would say. It's just the ability to keep everyone gainfully employed and their benefits in place as we went through it. And because there, you know, can't be, there's one and there's 1A, right? But I think for everyone in the room was just taking care of patients, you know. And boy, I mean, you know, the pandemic changed a lot, but it didn't change people's needs for health care. And probably the proudest thing was that secondary to our internal employees was hearing from our referring physicians and patients that we can still care for them. You know, we have an imaging center on Wolf River Boulevard. Hospitals were going through changes. Ambulatory surgery centers are closed. You know, governmentally mandated closures. But people still get appendicitis. You know, people still have cancer findings, and you know, be able to continue that care was really positive. And hearing on the back end from patients saying like, you know, thank goodness there's places to still get care was really positive as well. So.
We actually come from a different perspective, and I know this is a horrible thing to say, but COVID was our most profitable years we've ever been in business because it was a respiratory disease. Now with that also came the bad. I saw, you know, umpteen physicians extremely frustrated because at the very beginning they had no idea how to fix people, what worked, what medicines worked. We had weekly phone calls, we had death counts every day. When you come in on Monday, you had to hear how many people died over the weekend, all ages, all ranges of fitness, no explanations, it was just random. And then you were able to finally see them kind of get a handle on what worked and what was working, and talking to various centers all over the country. So that was kind of interesting. It was very heartbreaking and it was sad. We never shut down one day. My employees are still a little salty about that because they felt like they should have gotten some work at home time. But on the flip side, we were all up there together by ourselves. You could get to work in record time, and you had to bring a sandwich because there was nowhere open to eat for about a year. However, we're very proud that our staff is still there, our doors were open. In that time, in January of 2020, it seemed like a really good idea. We opened a 12-bed sleep center, and in March, everything just dropped, and we kept going. And our proudest accomplishment this year was from January of 2020, December of 2022, we paid off a $2.5 million loan from that. So we're free and clear. We were also able to decrease our overhead by a couple of percentage points down to about 32%. We thought that was pretty huge. We used that time, what little time we had when we weren't taking care of patients, looking at our processes and going over everything, because the most important thing to the doctors was the staff. Keep the staff, keep the staff, keep the staff. So like Brian, we had no layoffs. We kept benefits the same. We gave them several increases, and you know, we were able to push through. So ours is a little different perspective, but it ultimately we still had our challenges.
So I think really post-pandemic in 2022, the thing that I'm most proud of with the wage inflation and the labor market challenges is being able to pay our employees. You all know it's very difficult to get people in the door right now. We're all competing for people, and keeping their wages where they need to be, giving them a living wage, allowing for them to work remotely when possible. We've worked really hard to make sure that we could do that. We did not do any layoffs either. Healthcare is very different than a lot of other businesses and what they went through during the pandemic, but it's been really hard to keep people post-pandemic. And it's been hard. We've had to do merit increases, we've had to do market adjustments, and there have been years recently that it was very difficult to do that. I mean, we had to cut elsewhere to do it, but I think that's what I'm most proud of.
I think what I'm finding really refreshing from each of you is the fact that none of us actually laid off staff in the last year. And our theme at Christ Community this year is the mantra is back to the basics. Because I think for COVID and the pandemic, we were so focused on trying to keep individuals alive, test them, screen them, vaccinate them, serve the community, keep the doors open. And so somehow you can kind of forget, what's your purpose? Why are you actually there? And so it's refreshing to go back to the patient. The number one focus is the patient, serving the patient, keeping all of your staff employed. And so I'm really glad to hear that all of us were able to do that in the last year. So Shannon, you did mention some of the post-COVID challenges. So let's talk about that a little bit. What are some of the challenges that you're facing, and what could you say is a top priority for your organization this year?
So this is easy for me. So with the labor market increases, with supply costs, which we're all experiencing, the thing that hasn't changed is reimbursement. So, I mean, you don't have to be a mathematician to realize that the numbers don't really work that way. So our focus this year is really on payer contracting and reimbursement, and it's going to be an interesting year, but that is what we're focused on.
We are also focusing on keeping staff. We need better educated staff. The quality of the staff that has come out post-pandemic is not quite what it was pre-pandemic. And they're more, I don't even know if I call it tunnel visioned, but it's really more about them. They don't want to play with the pack, and they don't want to cross-train. And we've never experienced that to the degree we have this last year and a half. And for example, our sleep techs, that is you have to take a board certification. They can't pass it. They've done all this school. We've never in all the years we've done sleep and been associated with sleep centers, this is over the last year and a half, 90-something% of them cannot pass those boards. So we have someone for 120 days and we have to let them go because in the state you have to be board certified, which is, kind of a double-edged sword. You want the person who's well educated, but the people coming out are not educated. That in addition to having to do a lot more with less supplies, modifying our needs for supplies, and then just increasing efficiency, trying to deal also with physician burnout. We've got a lot of physicians who are burned out. They are tired, they've got people pulling at them from all over, and so we're having to do that. And staff as well, in case y'all didn't know, at our place, if you ever want a Starbucks, Wednesdays is Starbucks Wednesdays. So, we just had to really try some small things to motivate people and do a lot more cross-training and educating, a lot of lunch and learns. We use our reps for lunch and learns now, just to kind of help the staff feel like they're better prepared.
Yeah, our focus is mainly on I would say business development. I like to say that I keep on my desk I keep a crystal ball on my desk, and it's really whenever anyone our physicians come and ask me what the bonus might be at the end of the year, I look at it and it just never works. But we renegotiated our payer contracts right before COVID, and it sure made me look good. But boy, it was just a lot of lucky timing. And but what we're really focusing on is we work at a lot of hospitals. We cover 13 hospitals. We cover every Baptist hospital in the state of Tennessee, Arkansas, and some Mississippi. And boy, it's full. The hospital's full. People are sick, and we knew this was coming. When we look at population trends, 2011 was the first year that the Medicare, or the baby boom generation hit Medicare age. And they were anticipating about a 3% year-over-year rise in Medicare participation members, and we've seen that. And as most of y'all know, you use 10 times more healthcare in the last few years of your life than you use cumulatively for all of your previous years of life. So we're seeing a lot of people needing healthcare, especially in the hospital setting, and so there's other settings of healthcare. Outpatient imaging, obviously in our world, is important. If you can't get into the hospital for certain procedures, having that outpatient option is a really good venue, and through various partnerships and joint ventures, we're really focusing on getting getting the patient to the right place of service. And secondary behind that, our model of healthcare and radiology is very specialized. We're very focused on subspecialization. So if you're going to the orthopod for care and get an MRI of your joint or whatnot, we're going to have a musculoskeletal, trained musculoskeletal radiologist read that stuff. It's not going to be someone trained in another specialty or cardiac pulmonary. We really believe in getting the right radiologist the first time. So to do that, we have to be very subspecialized, and we need staff to do that. So developing those right places to deliver care most efficiently and effectively, and I'm sure we'll get to this, but also physician recruitment is really top. And for us, it's maintenance of that, but those are our two real focuses, developing those pathways.
Great, thank you all. Still interesting to hear. Most of us are dealing with recruitment, retention of staff, maintaining those salaries, coupled with business development. So looking at our processes, thinking about the future and how do we go from here. And I know for us at Crescent Units, how do we maintain salaries, yet also keep up with the environmental external pressures on us as a primary care organization. Insurance companies are still holding us accountable for outcomes, shared savings, quality bonuses, and things like that. So I will say at Christ Community, we've also focused on processes. We've brought in Huron Consulting to help us really with our system and the organizational infrastructure so that we can actually maintain shared savings bonuses and perform well. Looking at reimbursement as well, our model might be a little bit different because we're a federally qualified health center. So in terms of payer mix, our highest payer is Medicaid, but at the same time, we're looking at our costs and actually working with Medicaid to see how we can increase our reimbursement. So with that, this is a great segue into recruitment, retention of staff. So could you share with us some of your innovative approaches of how you are retaining staff? And Kim, you've already mentioned several ways that you're doing that now. Brian, would you like to chime in?
Yeah, I wish I could say I had some sort of great, plan or idea. I think, mostly I really fall back on charisma, but that doesn't, always work. But one thing that, and this predates me at Mid-South Imaging, I've been there 13 years now, is our group has always really focused heavily on the benefits side of the equation, and sometimes we have a bit of a challenge with, I would say, the younger generation, understanding how valuable, benefits are. And we pay for all of our employees and their families health insurance premium. We can do that because of the nature of our work. It's a little bit unique to being a very top-heavy, physician-heavy organization. And we interviewed a nurse this week and we're told, I don't care about benefits. Okay, thank you for that piece of information. So it's generational, but we've given increases, we've given raises. We're big believers as an organization. Is the organization, if we do better, everyone does better. So we're trying to get everyone to row that boat. in the same way, and that's from, you know, the person at our front desk all the way up to our physicians. So we've had to give, we call them, life adjustment raises. Not sure there's always a term for it, but, they're pretty high, I would say because of the nature of our specialty in radiology, we probably don't have as much of the challenges that other specialties have that have to have more, more nurses, more techs, more of those staff. We're just very physician heavy. But nonetheless, we do have those staff. We do have nurse practitioners and PAs and RNs and CRNAs and everyone. And so we've had to give raises. Right next to, my crystal ball, as I point out the window at my money tree, and it's just never produced, and so, because we do work with a lot of people who think, money just, like I have a printing press in my office somewhere, if it's there, I haven't found it yet, and so, it's a real challenge, and the way that we deal with that a lot is just communication. It's like, look, these are the numbers. This is what we can do. We do not print money, and we hope that by paying fairly, which I feel we do, we try to keep everyone in that 75th plus percentile. Maybe I'm mistaken, but and then really focusing on the benefits, and we have some, I would say, luxuries because of our organizational structure and specialty that we can do that, but it doesn't always work. It's a challenge. It's not just a challenge in clinical areas. Accounting staff is hard to find. Front desk staff is hard to find. It's hard everywhere. But so far we've had a bit of success, but it's probably no different than all of you. You have to pay more, and that's kind of the bottom line. Pay more.
To add a few more things, we do the same thing that Brian does. We also are pretty lenient on our PTO. Like we give everybody their birthday off. We make the 4th of July a 4-day weekend typically when it's front. So we also do that with Christmas and New Year's, and Fridays are Blue Jean days. But as much as we do, we find that it becomes an entitlement over time, and they don't appreciate it anymore. So we just try to find new ways to help the staff by education and helping them advance or get certifications that they want. It still doesn't work, but we'll never give up because we're always looking for staff. The other thing that we do, and this is actually on the physician retention side, the best thing we ever did, and it was kind of a long shot, we put nurse practitioners in the hospital at night instead of the physicians having to spend the night there as intensivists. And Vanderbilt has a wonderful nurse practitioner intensivist program that we make them attend for certifications. And that is probably, they'll tell you that's increased their longevity by at least a decade, a lot of these physicians. And it had never been done. Methodists had never used a nurse practitioner other than a scribe. So we had to get and write the protocols for the hospital and argue over letting them do central lines, intubations, things like that are now second nature to them. So all these years later, it's less expensive to have one in-house than a physician. It keeps the physician from being on call, especially our young ones. The young ones love it. They have a much better quality of life, and they'll stick around more. And we're pushing practitioners to the limit of what they can do, which is great because it's hard to find physicians too, not just staff, but physicians. So we look ahead to that, and we're looking at not only keeping staff, but keeping physicians happy.
So we have several things that we've done. We talked about wages. Actually, 2 months prior to the pandemic, we implemented a living wage, which was crazy that it happened that way. But during the pandemic, we had to take certain categories and do market adjustments like RNs just because it was hard to keep people. We've done merit increases, and again, it's been very difficult. It didn't always work, and so we had to give up other things to make it happen, but it was important that we paid them a living wage. Also, when the pandemic hit, I think we did a really good job of embracing remote working arrangements. Not everybody could, but we did some telemedicine, and some groups could go home and work. And so when we came back after the pandemic, and I'll just be really honest, I'm old school. I think you need to be in the office most of the time. But there are still some groups that can work from home. I mean, like our coders work from home. We may have people in the county that if they've got a sick child, the way we're set up now, we can say, hey, just work from home today. And that is a pleaser for these staff. Also, and this is something that Jessica actually implemented, is, we went for 2 years, 2.5 years, where you gotta stay 6 feet apart, you can't be in the same room together. And Jessica has implemented a monthly manager series for our group, and we have about 20 different locations, so we are dispersed all over Memphis. And she gets these people together once a month, and we present and we talk. We have a book club. We have different people present. But it has been great for the managers, the leaders, to really come back together and collaborate, feel some camaraderie, because that's really been missing for the past few years.
Well, I'm sitting here smiling on the inside, just hearing about everything that, all the efforts that you all are doing, and even just some of the efforts that we've put in place at Christ Community. And sometimes you feel like you're in an island on your own, thinking of these things and coming up with these things, and you realize that we're all dealing with the same thing in some form or fashion. We're all trying to make sure that our staff are happy. We're trying to make sure that we engage, bring managers back together. Jessica, I'm going to have my team reach out to you because we just started that as well. We have a management staff meeting tomorrow. I was talking to Roseanne about it. Just a few. Radical Candor, okay. All right, so we're going to all share these books that they're recommending as well. And so anyway, it just warms my heart to hear about all of the efforts and just to know that we're not alone. We're not alone. And even just for this setting, how important it is for us to come together for these types of events. And this is my first MGMA luncheon, but leaders need leaders. I mean, we need to encourage one another, especially amongst this group of CEOs. Sometimes it's really lonely at the top. And so you really need the camaraderie and encouragement of other leaders to hear about what they're saying. So just to change directions, let's talk about advocacy. And advocacy is a core focus for the MGMA. And so what are some topics or specific legislation that you're focused on at the local, state, or federal level?
Yeah, we try to be very, very active and proactive legislatively on all fronts, local, state, and federal. Our group, we have our own PAC, our own political action committee. It's at state level, local level PAC, mainly because we don't want to compete on the national level. We certainly don't have the dollars to compete on the national level, but the American College of Radiology is our representative there. But so we try to be very engaged in that. And two key pieces of legislation, I guess really for radiology, but it affects other areas of healthcare is, and I cannot remember the Senate or House bill numbers. I think it's Senate Bill 1345. I don't know the House bill side of it, but as most of y'all know, there's a No Surprise Billing Act that got passed federally, and that affects hospital-based practices in hospitals and ASCs as well on a number of fronts. Radiology is in many ways hospital-based to a large degree, as is pathology, anesthesiology, but it affects any hospital-based physician, neonatologist, so on and so forth. And it's a consumer protection bill, and that's great. I think we can all support not putting, a patient in the middle between a hospital that they think they're in network with or ASC they're in network with, and they get a bill from pathology, radiology, anesthesiology, and it's ridiculous. It's a ridiculous amount of money. That's just wrong. I mean, ethically, morally, I think that's wrong. But what it's turned into is the way the law has been interpreted on the federal level is it's turned into a real boon for the insurance industry. Not all insurance players. I don't want to cast a broad net, but an opportunity to renegotiate really untenable contracts. You know, and it's been obviously publicly here locally, so, you know, our colleagues across the street, they're our friends, they're our colleagues, we do a lot together. And the Methodist, or Memphis Radiological, that covers predominantly Methodist Hospital, they were terminated from Blue Cross Blue Shield, as was the anesthesiology group, MAG, and others as well. And really handed, my understanding is, you know, untenable contracts. Reimbursement rates for Blue Cross products that would essentially put them out of business. And I'm not privy to numbers or any other confidential information, but, you know, certainly, you know, it's not, you know, Memphis is not always the easiest place to recruit physicians to, as y'all are well aware of, but, that additional challenge has been quite burdensome. We haven't faced that challenge yet. We hope to never face it, but there's a state law working through or soon to be working through the Tennessee legislative process right now that at least addresses balanced billing and having a fair process at a state level. That will do nothing for ERISA plans, it's all federally administered, but it will at least address non-ERISA plans. Last statistics I heard was Blue Cross Blue Shield Tennessee, largest insurer in the state, approximately 80% of their plans are non-ERISA, is my understanding. And I hope I'm not, you know, not lying about that. That's what my statistics from memory are. So that's a big piece working its way through right now. And I would say number two for us, and probably for most of y'all, it's a TMA initiative, is a pre-authorization process. You know, I think you have to have like a degree in theoretical mathematics to understand the pre-authorization process. It is a real burden for our practice in the interventional radiology realm. I have no doubt it's a real burden for all of you. And you know, we'll get pre-authorizations for patients, do the procedure, and then get denied on the back end for not necessary. And these are really big, very specialized, yttrium 90 cancer type treatments. You know, just the doses. You know, we paid $17,500 for a bottle of yttrium this big, and that's money out the door. And afterwards, we'll get pre-authorized, and also we'll be able to pay for it. So those are the two big pieces statewide. I would say that we're very engaged in is a Tennessee level No Surprise Billing Act that protects the providers, and I would say a more fair, better pre-authorization process. I'm sorry, I should have done a better job. Kim does a better job. She has notes. But I can't remember the House bill numbers, the Senate bill numbers, but I'm sure Clint or someone can tell you that. But those are the big ones that we're focused on.
We are also focused on the No Surprises Act. We're considered ancillary providers in the hospital as an intensivist, so it doesn't matter if we tag onto a consent from the hospital, we can't balance bill anybody, whether they're out of network or whatever the situation. But in the office, we are geared with ATS, which is American Thoracic Society and Chest, on the good faith estimate in the office for out of network and self-pay patients, because right now, you can't give the patient a range, it has to be a number. And in a long conversation with SBMIC, we were discussing that HAS is talking about penalizing you if you just give them all high codes. You know, if you just kind of buffer it, because you know there's a $400 rule that if you go over $400, they can dispute the bill from what your estimate is. And we keep saying, well, an estimate is a range. Well, not according to the bill, it's a number. But you can't go over the number. But if you get too high of a number, you're going to get in trouble. So there's a couple of states, obviously Texas is usually at the forefront of all litigation. So we've tagged on with a couple of legislatures out of Texas for their 80% rule to see if maybe they can come up with, instead of this qualified payment amount, which just is a number all over the board. For example, Aetna, for an out-of-network, they paid 105% on one, 80% of charges, 40% of charges, 30% of charges. It's great if you want to sit there and have two people full-time argue this, but it's 30 days here, then another 30 days. So while you're moving your payment out, nobody's getting paid, and you're just really spinning your wheels. So that's what we worry about on that, is this qualified payment amount, and the good faith estimate, and the timelines on that. We also are with Brian, the pre-certs and pre-authorizations are out of control. It is out of control. There is no other way to say it. And if they give you a number, they should have to honor it and pay it. I don't care if it's not medically necessary. Whoever opened their mouth and gave you the number, that's on you. And we have a big issue with that we're dealing with. The other one is the number of Medicare Advantage audits. The audits are out of control with Medicare Advantage, and they give you this and they give you that, but you'll get 300 at a time. Well, I understand the reason, and honestly, you will never convince me it's for the patient's quality. It's so they can get a better code and adjust it up for themselves, not for you. Someone needs to prove that to me otherwise, so we would like for some serious controls to be put on these Medicare Advantage. They need to be treated more like Medicare. Take away the benefit that they're giving, because they sure don't give a benefit to the providers.
So I'm going to echo the No Surprises Act, and I will tell you that I actually had an insurer. I mean, this is giving the insurers the upper hand, and that was not really the intent of it. But I had an insurer basically send us a term notice and lowball us. And when I pushed back, they quoted the No Surprises Act and said basically, because we have a lot of hospital-based providers as well, and said, if you don't sign and you go out of network, you're going to get paid less because of this. And that's sad. It's really sad. It ends up hurting the patient. I will add that I am focused very much on the FTC's proposed non-compete rule and how that impacts physician contracting.
All right. I think we're coming to the close of our discussion in the next 5 minutes or so. So I want to ask this last question of our panelists. Considering that MGMA has and is continuing to work on new offerings that are focused on professional development, especially for leadership, each of us on the stage have worked a long time to get into the roles that we are currently in. What advice would you give to those who are aspiring to be CEOs in the future? We'll start with you, Brian.
I don't know what you're talking about. I'm young. I mean, it's been a long time. I'm just kidding. But, my wife recently reminded me yesterday about I played sports, crack a lot of places, and my son who's 10 was like, "You crack a lot." And I sure do. And but I'll tell you the same thing. I've had one opportunities to go back to my alma mater for my MSHA, MBA, which is UAB. I went to college here locally at Rhodes, although I was a biology, science nerd. So, and talked to students there as well. And I get this question a lot from those two places and others. And honestly, my honest answer to them is really twofold. One is do the hardest job that's out there. The job that no one wants. And when I started my career, I moved back down to Louisiana. I moved back on July 5th, and then on August 29th of that year, 2005, Katrina hit. And, I like to think I'm a pretty informed person, but I was actually playing golf in TPC, Louisiana, in Avondale, walked off the golf course, and there was a line of cars leaving New Orleans area, and I'm like, what's going on? They say, oh, that hurricane is coming. I'm like, oh my God. And you get on the phone, and it's like, oh, that's not going to be fun. And it wasn't fun, I'll tell you that. It was no fun. But there's a parish next to Orleans Parish called St. Bernard Parish. Most of you have never heard of it. Been to New Orleans, you've probably never been there. Borders the lower Ninth Ward, which probably none of y'all have been there. You have no reason to be there probably, but it was decimated. I mean leveled. I'm not talking about, empty houses. I'm talking about no houses. I'm talking about the hospital there was leveled. Think bulldozer coming through, rubble on the ground, level. I saw massive, huge dumpsters. I don't know how much they weigh on top of 3-story buildings. I mean, Mother Nature is a force to be reckoned with. No health care, nothing. people, I mean, you talk about, I mean, unfortunately, I saw people die of strokes in the middle of parking lots. I mean, it was not a fun experience. And so the hospital system I worked for is a Catholic health system. And the sisters who owned it, ran it, said, they don't go to places they're invited. That's their rule of thumb. And I kind of live by that rule of thumb too. I'm not going to go any place unless we're invited, and people that want to work with us, we want to work with them. And they were invited to the community. There wasn't anyone in that organization who wanted to go down St. Bernard Parish and do healthcare recovery. I think, I wanted to do it because it was my home, it's close to the area, but, and I think, and the second reason was I was the only person who had to get there at the whole health system. But I started in a double-wide trailer in the middle of a Walmart parking lot, restoring all health care to that parish. All health care. We had 2 doctors, we recruited an employee, we got to 3, and we got to 4, and we got to 5, and we got some staff back. And then we got, with a lot of government assistance, we got a 55,000 square foot modular building brought in by FEMA, and it was in a Walmart parking lot. It's not like this. It wasn't glamorous, but boy, learned a lot. Drank from the fire hydrant directly, and no one wanted to do it. And so I did it, and learned a lot, and met a lot of people, and got involved in everything from federal government to state government and all across the board. And I think no matter kind of, we were talking about a colleague of ours who always sees the silver lining in the dark cloud, which is a great position to be in, but there is a silver lining into a dark cloud. And I would say do the job that no one else wants to do, because you're going to have free reign, it's not going to be bureaucratic, and you're going to probably learn a lot. And then second behind that, I tell a lot of people is, to get the job you want, sometimes you gotta move. I moved, I moved a few times. I hope I don't have to move again. But sometimes that job is just not where you wanna be. I tell, we have residents, we have medical residents we train. We recruit staff in, and I tell them, when they're looking for a job, they're looking for 3 things. And I swear I'm gonna copyright this one day, but take it and make it your own. I tell them they're looking for 3 things. Professional satisfaction, fair compensation. I have to really stress that to the doctors, that fair compensation, not excessive compensation, and location. And my rule of thumb is you're going for 2 out of 3, and you'll be happy. You can kind of run those scenarios however you want. You get 2 out of 3, you'll be happy. You pick 1 out of 3, and for the doctors, it's usually compensation. Surprise, it's for most people probably. You won't be happy, and you'll leave that job in like 2 or 3 years. And if and pretty much, I'm batting 1,000 on that philosophy, but those are the 2 things. And location is important to some people and everything else, but if you want that opportunity, you might have to move. And that's a big decision, especially with a family. So those are my 2 things. Choose a job that no one else wants, it's hard, you'll learn a lot, you won't have a lot of, I would say bureaucracy, and then sometimes you have to move to get the job you want, or take that step to get the job you want. So.
I would say from my experience, be flexible. Inflexibility is a killer of people. Be flexible, admit when you're wrong. I'm the first one, because the staff loves it. They'll sit there and go, well, that didn't work. Oh, yeah, I know, that was kind of a boneheaded thing, but hey, whatever. And usually what I'll tell them is it may not have worked now, but it might work at a different period in time. Just because it didn't work now, maybe it wasn't the right time. So I'll always admit if we did something that sounded good, but really didn't turn out to be. And then never feel like you're too good to do a job. Any of the positions that any of my staff members have, my office manager and I have done all of them, and can easily slip in and help them when we're in a pinch. And when we were so down on staff at a point in time, if you called the office, you got me sometimes. I didn't know what I was doing, and I apologize if I hung up on a lot of people, but eventually we got it. So be willing to do every job, and even like you said, the worst jobs. I've cleaned up some really bad stuff that I had no intentions that day of doing, but you just got to do what you got to do, and I think that gives you a lot more credibility with people.
So I see a lot of young people coming out of college and they've got the degrees and maybe the internships, and they come in and they immediately want a leadership position and they want to climb up the ladder. I mean, we've all dealt with it. It's like a pet peeve of mine. I think what I would say to them is be patient, learn what you can learn, be willing to roll your sleeves up and do the hard stuff. I will tell you, during COVID, we worked with Christ Community and with Church Health. We ran the testing sites, we ran the vaccination sites. I drove a golf cart, y'all, to bring water to people. Be willing to do whatever it takes, because leadership is not about you, it's about the people that you lead.
So I echo everything that you all said. I put on my paper, be humble and be patient, especially for young people, because honestly, to get to where we are, you have to be willing to take those hard jobs, the jobs no one wants. No task is too small. No job is too small. Honestly, it gives you great insights about the organization. Once you become a CEO, you know everything. You know everybody's job except for actually seeing a patient. And so it gives you great insights when you're a leader. And then the other thing that I would say is prioritize development is very important to make sure that you're reading, staying abreast of changes in healthcare, and then seek a mentor. You need a mentor to guide you along the way, somebody that you can talk to, that can share their experiences with you, and they're really just shepherding you through your journey. Lastly, mine would be pursue your passions. Pursue your passions, because you will be really happy when you do that. All right. So I'm looking around. Jessica, do we have time for questions? I'm not sure we.
Well, we're kind of running
Okay.
short.
Yeah, we're running short. Are there any questions from the audience? We'll take one or two, and then we'll make sure everyone leaves on time. Yes, ma'am.
I have one question. Particularly to you, since your biggest payer is Medicaid, are you doing anything special to prepare for the upcoming disenrollment that's about to? Are you all doing anything special already?
So we're standing up an enrollment department so that we can educate all of our patients when they come in about the disenrollment process, and even for some of those adults now that TennCare is actually providing adult dental benefits, we're also educating them about that new benefit. So we're striving to educate them as they come in, you know, make sure that they're still enrolled, and that we can easily get them back enrolled if possible. But those are some of the things that we're doing. We have really about 40,000 lives assigned to us. So if a significant portion of our population is disenrolled, that will be devastating to the organization. A great question. Other questions? All right, hearing none, thank you for your time today. Thank you, panelists, for sharing with us. It's been our pleasure to facilitate today's discussion. So I think I'm going to turn it back over to you. Are there any closing remarks?
Not really. Everybody
Okay.
have a great, the sun is coming out. It's great. So everybody be safe, get back to work. We'll see you soon.
All right, thank you. Have a good day.